and an honor for me to be the moderator for this first panel discussion at this very first inaugural meeting of the Surgical Palliative Care Society. I am a surgical oncologist from Charlotte, North Carolina, and it's just an absolute pleasure, and I want to thank the leadership for inviting me. So what we're going to do, we're going to have a series of very cogent presentations on some very important areas, and we want to leave some time for discussion. So I want to call on first Dr. Tim Siegel, who's from the Oregon Health and Science University School of Medicine in Portland, Oregon, to give us his talk. And so Tim, this is going to be incorporating education and the surgical curriculum and community.
Thanks, Dr. Green, and thanks to the Society for the invitation to speak. I'll see if my clicker works.
We don't think
I don't think our clicker.
We don't think the clicker is working.
I'm ready. Great. Okay, I'll try it in a second. So thank you for having me. And because a lot of you haven't ever seen a talk from me, I always have a dinosaur on my title slide. And the reason is many years ago, I was always kind of running late, and I walk into a patient's room and the patient said, "Oh, you're Dr. Siegel from paleontology. I've been expecting you." So that's why I have and I have no disclosures, although I do think that I've always kind of, I would say, suffered to talk about what Dr. Hinshaw was talking about, because Dr. Schwartz, who is my chairman, he told me when I finished, he was disappointed that I wasn't going to be an academic surgeon. I wasn't going to do research and write papers and stuff like that. And so I've always kind of been on the fringe of academia, and I teach basically is what I do. So I'm sorry, Dr. Schwartz, but I'm trying to do the best I can. And then in the middle is Tim Quill, who was, at the time I knew him, was an internist in Rochester, but of course became one of the real founders of modern palliative medicine. And he was a great influence on my career. And I can remember sitting in his office and him being very, very encouraging about pursuing palliative. And then on the right, we all know who that is. That's Jeff Dunn. And I think the real issue and the reason that this is so important is because things have changed. And back in the day, we had books and we read books, and now there's just phones. And I think people are like playing candy corn on their phone, and they're like looking stuff up and like important stuff. So that's a big difference. But I think the volume of knowledge is ridiculously enormous, and there's definitely generational differences we see in students and residents. They're not learning stuff that we learned in medical school in my day. And the first person there next to Dr. Schwartz's book is Dr. Almy, who was, as many prominent physicians ended their career in Hanover, where I went to medical school. Dr. Almy became the chairman of medicine after a career in New York. And he was, I realize now, was on the forefront of shared decision-making. And he came to talk to us. He was in his 80s, and he had BPH, and he said, "I'm not getting a prostatectomy. Nobody's going to tell me I'm doing it. I dribble, and that's okay, and that's my choice, and nobody's going to tell me what to do." So it's kind of interesting. And then in the middle there's Ted Hirakawa, who was just a hero to me as far as patient communication. He was a general and vascular surgeon, and really taught me the principles of what we now consider palliative surgery. And Joe Geary is just one of the greatest guys, who also taught me the power of direct communication. So what's out there? I'm going to fly through this, but there's the SCORE curriculum. There's the ACS Surgeon's Guide, which in the Shameless Commerce department we are revising on the ACS committee. And then a lot of papers out there are single institution and little interventions, which are excellent. And I don't have time to review them, but there's a great paper there at the bottom that's recently published that reviews a lot of this stuff. So I direct you to that. So we had this problem. We want to incorporate palliative. So first thing you got to do is define it. And then we asked the residents what they thought, and then we asked the faculty what they thought, and then we just did it. So, which is kind of ironic because we're in Portland where, you know, the swish is from. On the right is Matt Cook, who is one of the most wonderful people I've met. He's a trauma and acute care surgeon, and he does all the stuff that I do. Like he thinks up stuff and thinks up research stuff, and he writes papers, which is great because he asks me what I think and he puts my name on the paper, which is great. And this is the paper that kind of started it. We asked residents and faculty what they thought. And this is kind of what they thought. They wanted more experience. They wanted a program. And the faculty also wanted that because they thought that the residents weren't properly prepared. And that last thing was amazing to me, that the residents hadn't really been in the pre-op situation where they were talking to patients in the clinic. So we wanted to address that. Before we address that, I have to acknowledge we had this spectacular curriculum that was started by Karen Devaney, who's a true hero to me. She was the program director at OHSU. I remember interviewing her when I applied, and Rochester was my first choice and OHSU was my second choice. So who knows what would happen if I ended up there. But she and Karen Kwong got a grant about 10 or 15 years ago and started this. So I walked into this and they just said, hey, can you come help us? And so every Monday, we have the residents by year, and each year gets 4 weeks, and we have a curriculum with papers and cases and stuff, and we kind of go through all this kind of stuff. So I kind of walked into that, which was really, really great. And the thing that kind of blew my mind, having been other places, is the residents all showed up, they all did the reading, and they all participated, which was like, wow, where have I landed? So it's kind of great. And then we thought very consciously in the program, in the residency, and in the department of a continuum. So we wanted this to start with medical students, go through the residents, but also include fellows and also faculty. And so what we do, we have a medical student curriculum, and Matt Cook is the clerkship director. Vahag Nikolin is the associate director. I give a talk on the first day of the clerkship. It's an hour long. We talk about surgery, talk about palliative care, why the two are necessary and work together. And then in the middle of the clerkship, I meet with the students for an hour. We talk about difficult communication things. We talk about the power of self-reflection and reflecting with your colleagues as a way to maintain your resilience and to mitigate burnout. And then we also talk about a death debrief at that session. And then on the last day of the clerkship, before they take their OSCE and do their exams and stuff, we do a debrief and we talk about what's happened during the clerkship and stuff. And the students really, really like that. So we do that. And then they have a bunch of asynchronous content. There's papers and stuff that Christian Cannell, who's up on the right corner, he was a resident. He's now a transplant fellow at UW. He put all this stuff together, this asynchronous content stuff. So really, really terrific. Then we have a 5-year plan, which I'm going to fly through at the end of my talk. And then we have the ICU critical care fellows have an option of rotating with me on the palliative care service. Probably about 75% of them do it. They all kind of like it, or at least they say they do. We have a difficult conversations dinner, which is based upon that book. And then in the right lower corner, that's David Zonies. He's the head of ICU for OHSU across the health system. He's also boarded in palliative, and he's also a great guy. And so we have that dinner, and then we also do trauma ICU debriefs when there's a difficult case or a death or there's provider distress. So again, we're trying to make it not just the rotation of the residents with me, or not just the residents. And then for the attendings, we do, based upon New Mexico, we do death rounds where we discuss difficult deaths, not from a medical standpoint, but from a personal or emotional standpoint. And that's been very, very well received. We have a pretty active peer support system for when there's a colleague has a complication or a death. So I'm involved in that. We do debriefs after difficult deaths. And then we have, it's interesting to see the change in the focus of M&M presentations since we started kind of ramping this up. And then we have a journal club that meets kind of quarterly. So then this is the thing that I was really wanting to do when I got there, and it took a couple of years to get it off the ground, but we have a surgical palliative care rotation for our categorical interns. It's not an elective, it's required. They each spend 4 weeks with me, basically, so there's always somebody to talk to, which is nice. The goals and objectives. And I was so proud because that's Karen Brazel, but for those of you who don't know, she's really phenomenal. And the reason that we're doing all this stuff, yeah, she's really original member of the committee and all this kind of stuff. And then Matt Cook, who's the greatest guy, he always does those boxes in his talks. And so my son, who's a software engineer, did that for me. So I can't do that, but it's there. So if you can go right to the paper from that. So it's very good. But anyway, that has the goals and objectives and stuff like that. But people want to know what's the rotation. So Monday morning we have our M&M and the surgical residents have their education time. That's when we do our ethics and communication thing. And then so they're always doing that, and I'm always doing that too. And then we meet up in the afternoon. We make rounds together. Tuesday is the day I'm at the VA. We do one day we do clinic, which is really fun. And then the other days we do operating room or endoscopy, whatever I'm doing, they do with me the other Tuesdays. And then we go to tumor board, and then we get some cases from there because I also do a high risk surgery clinic Wednesday afternoon. So they do that with me. So basically just kind of do everything I do. And the same thing, we do that on Thursday and Friday. And then the Friday night they take call. And sometimes when I'm on call, like, I can't believe Dr. Siegel, you're on call with me, but that's kind of fun. So with that, and we've been doing that, and this is now our 4th year, and not to do a spoiler alert or anything, but on the ACS symposium, we're going to have the results of what the residents think of that. And it's good. So I don't want to spoil that, but it's good. That's very good. And then we thought, what else can we do? Because that's kind of an apprenticeship model. And we wanted to get them a little more comfortable with these conversations. And so we just started this past May, this Mastering Tough Conversations course. Up in the upper right is Annie Nagengast. She's one of my colleagues. She's boarded in palliative. She's a trauma surgeon that works at the VA. And then on the bottom is Katie Stowers, who just got into her college Hall of Fame for softball. She was a softball pitcher. And she runs our communications center. Her husband is one of my partners at the VA. He's a general surgeon. She's a hospice and palliative medicine runs our fellowship too. So she's like the Vital Talk person. And so it's called Powered by Vital Talk because we use a lot of their stuff, but we kind of lightened it up a little bit and leaned it down and wrote some cases that our residents would be interested in talking about and not having like it be something that they weren't interested in. So they're real cases from the ICU. And we use simulated patients, and we do 2 2-hour sessions. And we decided very intentionally to do it at the end of the R1 year, because at the beginning of the R1 year, which is when our medical colleagues do it, they're learning how to write orders and give Tylenol and stuff. So we figured that's going to be overload. So we do at the end of the R1 year, 2 sessions. And then we just did our first refresher for those residents in October. It was amazing that they really loved it. And they thought it was good. So that's terrific. And then we're gonna implement a thing for the end of the R4 year too. And this is what we talk about. And what I'm going to close with, I hope, is this. This is all Matt Cook's work. And so I asked him if it was okay. But this is what we hope to do. And this is what I think it could be a plan for the Education Committee and the In-Training and Residence Committee, is to kind of define the unique skill sets that palliative providers have. And then and at the end of their 5 years, they could do all this stuff and all this stuff and all this stuff. I'm in a rush, so I'm gonna fly through it all, and then we can do it. We did it by year, so I'll share all this stuff. Anybody wants my slides, you can have them. This is all. I'm doing this because I want to make the place better, you know. So that's that. And so one thing that we're trying to do is get a surgical palliative service going. That hopefully will happen in 2023. It'll be a hybrid of the inpatient palliative service where I am, and then also the emergency general surgery service. I would love to have a track in our fellowship for surgeons, but really what I really want to do is have an experiential pathway for surgeons that are out in practice to come spend some time in an accelerated format and be eligible for the boards. Because I know that people who practice surgery for a while, they know a lot of stuff that they need to know, and they just need a little help because there's the need. We're never going to do it with just fellowships. So that's kind of what I'm hoping for. Ooh. And then, yeah, that's the goal, is to not only be ubiquitous, but to be everywhere. So thank you very much. Sorry to be so short.
Tim, that was magnificent. Our next presenter is Dr. Elizabeth Lilly. She's a Sir-Jonk Fellow from the University of Texas, MD Anderson Cancer Center. She's going to talk about the priorities in palliative care research.
Thank you. Okay. Thank you all for letting me talk to you a little bit about the research priorities in palliative care. Okay. So when we think about research priorities in palliative care, I think that there's a couple things that I want to make sure that we're not taking for granted. Things that I believe are that palliative care is really about quality. And so when we talk about patient care, we're talking about quality. And we cannot define quality without our patients because it's their lived experience. So patient engagement is an important integral part of this quality assessment. The last part is something that I really believe, which is that practice change must be driven by evidence in order for us to do the best for our patients. And so I want to start by just talking a little bit about advanced care planning. For those of you who don't know, there was a little bit of a controversy in palliative care in the past year when a very famous palliative care physician wrote an article published in JAMA, and it was titled, "What's Wrong with Advanced Care Planning?" And the answer is he had a lot of things that were wrong with advanced care planning. So when we're talking about advanced care planning, I'm not talking about what we do when we're about to take a patient to the operating room or when we're talking about an immediate need to know about a surrogate. This is advanced care planning for everyone. And he pointed out that in 30 years, it had emerged as the #1 thing that people think about when they talk about palliative care. Advanced care planning was thought to be the solution to poor quality end-of-life care. And what happened was there was a major investment, millions of dollars in research, quality improvement initiatives, probably at your own hospital, certainly at mine, that were all centered around this idea of advanced care planning. However, the science does not support advanced care planning for patients. They found that advanced care planning in over 1,600 articles in a systematic review, in actually 80 systematic reviews, found that advanced care planning does not impact medical decisions, does not improve goal concordant end-of-life care, and does not increase the perceived quality of care from the perspective of patients and family members. This sent shockwaves through the palliative care community. This is a really uncomfortable answer. And so what is the harm? Because advanced care planning, it seems like it shouldn't cause harm, but there is some harm. As those of you who have ever applied for a research grant know, there is a limited number of resources. And if money is being diverted to projects that aren't necessarily successful and impactful for patients, there is harm there. There's harm when Medicare and other payers are accepting this as a quality metric and saying that this is something that if you're not doing it is a bad thing. And there's harm when there is false confidence in a document that may be outdated, may be irrelevant to the operation that you're about to do. And that document prevents a meaningful communication from happening. And so when we think about what happened with advanced care planning, I think that there was a commitment to trying to improve the quality of patient care without evidence to actually suggest that this was the right way to go. So why do we need research priorities? I think we need research priorities to prevent that from happening again. People have been fighting really hard to get palliative care to be as accepted as it is now, and in the future, even more accepted. But in order to get it universally accepted by patients and other surgeons, we need to have evidence that shows that this is actually impactful for our patients. We need to focus our attention to the actual research knowledge gaps. We need to target areas that will actually have an impact on patient care from the perspectives of patients, families, and other stakeholders. And we need to minimize redundant work on questions that have already been answered. For example, advanced care planning. So palliative care research priorities is kind of a vague idea. There was a systematic review done in 2020 that looked at international palliative care publications, and it excluded publications that were focused on specific populations. So this does not include the priorities of surgical patients. But they did identify 8 themes, and they mapped it into a Donabedian model, and they said these were themes related to structure, process, and outcomes. And I think what's interesting here is there are some things that are universal. There are things that are priorities when we think about research in palliative care, and there's some things that might not really apply to our surgical patients. This is because surgical patients are a unique population. They have a different disease trajectory from someone who has congestive heart failure or end-stage renal disease. And very often, particularly for our sickest patients, this can be a very turbulent, uncertain time. The surgeon-patient relationship is different. We're doing very invasive things to people that we've met maybe once or twice. And this relationship needs to be respected and nurtured. And the existing body of evidence, I think, is an important part of thinking about our research priorities, both in terms of what is available to us as surgeons and what has been shown to be successful and helpful in other patient populations, but has not been studied in surgical patients. So in 2003, the American College of Surgeons work group created a list of 7 priority research areas. These research areas, when we did a systematic review in 2014, we found that there were still significant knowledge gaps. And so the idea that we then had was maybe these research areas are either difficult to define or a little bit broad and hard for us to study. In 2017, the National Institute on Aging and NPCRC got together and said, let's go and identify research priorities from subspecialties. Subspecialties including nephrology, subspecialties including pulmonology, and thankfully subspecialties including surgery, recognizing that our patients have significant need. And so from this work group, there were knowledge gaps that we examined through the systematic review, but then also focused on what questions can be answered. What questions can be answered in the next 10 years that would move the needle on palliative care research. And we also proposed study designs, potential studies out there in the open, published, and saying, hey, someone take this idea and run with it. The research priorities that we identified map into 3 major categories: defining outcomes that matter to patients. And this is really where patient engagement is absolutely essential. Patients and families are the ones who will tell us what priorities we should be studying, what outcomes we should be studying. Communication and decision-making, trying to align surgical treatments with patient outcomes that patients say we should care about. And I want to just point out that this is not the same as advanced care planning. These conversations, these just-in-time critical pause conversations that we have on a daily basis with our surgical patients are different from the hypothetical, you who feel great, and then maybe 10 years down the road, what would you want? This is a very different kind of conversation that we have on a regular basis. Preoperative advanced care planning and preoperative decision-making, but also postoperative decision-making. When that bad thing does happen, how do we communicate that? Not only that something bad has happened, but that maybe the goals that we were hoping for might no longer be attainable. And the last thing that we included in this priority list was delivery of palliative care to surgical patients, which sounds like a really broad thing. And it kind of is a really broad idea, in part because we know that palliative care is a limited resource. Palliative care clinicians are very generous with their time, but their time is finite. And in order for us to best partner with them, we need to figure out how to use our primary palliative care skills, how to hone those primary palliative care skills, and how to create a sustainable and scalable model that can be replicated not only in academic centers and tertiary and quaternary hospitals, but in community hospitals where there may be only one palliative care clinician managing a whole lot of patients. So what are the priorities for the future? That was 5 years ago. And so what are the priorities now? And I think that the priorities as we're thinking about how they have changed, part of the questions we should be asking are there any knowledge gaps that have been filled by research? For example, the randomized clinical trials that have been being performed looking at surgical palliative care, specialty palliative care. Are those answering some of these questions, and should we be moving on to better questions? Are some of these priorities still relevant? In particular, with practice changes, with this incredibly inflammatory article that I started talking about with, should we be calling what we do advanced care planning? And I would argue, no, we should not be calling it that. We need to find a new term, and we need to change the way that we think about it. And are there better questions that get to the root of underlying driving factors that would help to change this research landscape? So when we think about the Surgical Palliative Care Society, how do we as a society support research? And I think that this is a really interesting question that I know Erin and I have been talking about quite a bit. I think there are many ways that as a society we can support research and researchers. First, by having a quality and research committee. Second, by collaborating with other organizations and saying, you know, there is an NPCRC, there is a number of surgical interest groups, and we should be combining our resources and our skill and experience. And also reaching out and engaging with people who have an interest in palliative care research and may need some mentorship because they haven't had that experience yet. I think that the things that are needed in the immediate setting are an update to the state of the science. The systematic review that we wrote is almost 10 years old now, and definitely severely needs to be updated. A revision to these research priorities to be based off of a new systematic review, and a way to define best practices for research going forward. So I would like to thank you all for your time, and my email's there. Please feel free to reach out anytime.
Beautifully done, beautifully done. Dr. Audrey Spencer, who's clinical assistant professor of the University of Arizona, is going to continue this theme because she's going to tell us about challenges to research in the trauma population. Dr. Spencer?
All right, good evening, everyone. Thanks so much to the program committee and also to the founding members for inviting me to be here. I think this is incredible to be part of this panel, and I'm super excited to talk about this. So I did my fellowship in trauma and critical care at Wake Forest University, and under the mentorship of Buddy Marter, kind of fell into surgical palliative care accidentally. I had a skill set that was kind of suited towards palliative care, and I've been doing quite a bit of research over the last 3 years. So other than being the co-chair for the Liaison and Advocacy Committee, I don't have any other disclosures. I'm opening with this proverb. I have this tattooed on my foot, and I think it's very fitting because I think it completely describes research in general, and particularly research in surgical palliative care. I spent a lot of time gaining a lot of momentum, putting a lot of hours, a lot of sweat equity into these projects. I get to this peak, and I think I'm just about to reach a point of success, and I go tumbling down the other side to the very bottom of it just to find myself needing to climb back up another mountain afterwards. So I think this is very suiting about how we do research in the palliative care space. why is this so important? So to build on what Liz was just talking about, we have an aging population, right? People are living longer with chronic illness. So I think there's going to be an increasing need for palliation and especially surgical palliative care specialists going forward. Healthcare approaches are very much multidisciplinary now. So we are needing to combine efforts with other subspecialties. And our quality assessments are really driven by patient-focused outcomes, right? How the patient feels, what they think about their care, how satisfied were they with the care that they received, even at the end of life. And then I can't really ignore the fact that the pandemic had tremendous effects on what we're doing in the healthcare system now, right? We're all short resources. We are losing staffing. Patients are coming in kind of extremes of physiologic states. And, I think our failure to rescue rates are increasing because of that. And so a lot more people, just because of the pandemic and our limited resources, are going to need palliation. Here are some of the barriers that I want to talk about that are really important when you think about doing research in surgical palliative care. So in 2014, the group out of Cornell, the Department of Geriatrics, they went and they interviewed the 80 top researchers in the country in palliative care. And they said, what are the perceived barriers to doing research in this field? One, like she talked about, is funding, right? There's not a lot of interest garnered in this subject. It's very specialty focused. And so when you talk about, am I going to give you $1 million to study how to treat blood pressure or find the next cure for cancer? Or am I going to give you $1 million to study palliative care? Blood pressure and cancer are going to win out every time, right? So it's very difficult to get funding, secure funding, especially on for deep pockets. Institutional capacity and workforce issues are another thing that are a big problem because palliative care, we have 4,400 or so palliative care specialists in the country. So that's like roughly one doctor for every 20,000 patients that need palliation of some sort. So we really we're so busy clinically that we don't have time to really invest in the research that's necessary. And then, the population itself, you think about the proximity to end of life for somebody who needs a palliative care specialist, right? So there's a very high attrition rate for these patients that we want to involve in these studies, and that makes it very difficult. And then the subject matter itself, right? There's still lots of misconceptions out there about what palliation is, what palliative care is, and people simply don't want to talk about it because there's cultural differences. They've already made up their mind that you're just talking about end of life and that's it, or withdrawal of care. So it makes it really difficult to study things in surgical palliative care. I'm very lucky. I showed up on the doorstep of Wake Forest for fellowship, and it's a huge hospital. They have a children's hospital. They have a state-of-the-art cancer institute. They do a lot of admissions. You can see there, we have a huge level 1 trauma center. And then the palliative care service was surprisingly robust. There's 5 physicians. They're all boarded in hospice and palliative medicine. We have 4 specialty trained APPs, and then we have a slew of case managers, pharmacists, support nurses, the chaplains. So they really can handle quite a bit of, the consult load the volume is really quite incredible there. And I think I'm very fortunate to have stepped into that situation where it was a perfect balance. And Buddy, being a surgeon and a palliative care doctor, right, he had already pre-established that relationship with our surgical department and the palliative care department. And then I just came in to build on top of that relationship. And what we did is we brought all the stakeholders to the same table. So all the acute care surgeons and the palliative care group. And we said, we're really going to incorporate palliative care into how we provide care to the emergency general surgery population, right? The 80-year-old guy with heart failure that needs his colon out in the middle of the night. Same thing with these really young trauma patients. We have 17-year-olds with severe TBI that are going to be, on a trach feeding tube for the rest of their life in long-term care. And so we really started to partner, and that's how these research projects that I got involved with really started. So this is what we looked at. We wanted to see one, we had this palliative care service and we were incorporating it into the trauma service and the acute care surgery team. We wanted to see the impact that particular service or the extra value add essentially is what we wanted to study. And so we just recently found out that this was accepted for publication in Injury, but the first study that we looked at was a propensity match. We went back and looked at our EMR. We took all the patients over the last 2 years that had had a palliative care consult, and then we matched them based on injury profiles to patients that didn't have a palliative care consult. So there were 140 matched pairs. And what we found was that with palliative care intervention, we decreased total hospitalization costs. We dropped it by half almost, and increased our rates of discharge to hospice when palliative care was involved. The one thing that we didn't find was that we didn't improve our ICU length of stays, our vent stays, or the stays in the hospital, which was contradicted to pre-existing literature that was out there. So that was a little bit odd. But we presented this at East earlier this year, and it was really well received. And like I said, we just got the acceptance on the publication and injury, which was a big celebration for us. And then the second step of this was after we saw what the impact was of the palliative care service, then we wanted to see, well, you know, there were some findings that were kind of incongruent with other studies that have been published. So what are we going to look at now? We wanted to see if the timing of those palliative care consults had any effect on the outcomes for the patients. So this was 166 trauma patients that had palliative care consults. And then we set a cutoff at 3 days. So were they an early palliative care consult or were they late after that 3-day benchmark? And what we found is in the early group, they had a decreased length of stay, they had decreased hospitalization costs, decreased vent days, fewer trachs, fewer surgical feeding tubes. And very importantly, there was no difference in the mortality across the two groups. And so this was just presented in Chicago a couple of weeks ago at the AAST, and we're currently in our revision for the manuscript right now for that. So what are the challenges that we kind of face as we go through this process and we're doing research in palliative care, surgical palliative care? Practice models are like apples and oranges in this country. I think, you know, Wake Forest was very unique, but I don't know that there's another palliative care program that's set up just like that, right? There's various numbers of palliative care medicine practitioners at each institution. Some institutions don't have them at all, and they're relying totally on primary palliative care skills. And then we had issues with our data set. So our data was all pulled from a dashboard that was designed basically to monitor the palliative care service and to see how it was being utilized across the hospital. It was not designed to collect data points specifically for research. And it didn't communicate very well with our EMR either. So 90% of the data that we pulled was actually hand pulled, and, you know, me at 2 o'clock in the morning, chart checking, that kind of thing. So that goes back to the workforce shortage and the time, right? Like if I'm busy clinically, who's going to be up till 2 o'clock in the morning, like chart checking for a data set. There was no money. This was not funded. So this was me and some medical students and Buddy hacking away at this data set. And then, you know, revision after revision after revision, it gets pretty exhaustive. So it's very hard to stay motivated when you're trying to get something off the ground like this. And then lastly, I want to make this point about generalizability, right? Because it's important that everything that we do, if we have apples and oranges practice models, how can we take what we've learned and then make that applicable to your facility, whether you have one palliative care provider or you have 10, how can we make this universal across the group? And this is important to think because this is where I'm going to ask for your help. I would love to collaborate with anybody who is interested in surgical palliative care research. I look obviously specifically at the trauma and the EGS populations, but I think it's important to start to identify triggers and screening mechanisms for who would benefit most because our palliative care resources are so scarce and that time that they have to spend with the patients is finite. So I think screening or triggering tools would be really useful. Obviously, I would love to do something multi-institutional because I think external validation is very, very, very crucial to this. And then, you know, it's not just about the numbers. My background is in finance, so I naturally look at things like numbers and percentages and dollars and, you know, communicating with hospital administrators. This is how you get their buy-in, but it's also about the qualitative component too, right? How do the patients feel? Do they feel their symptoms are being managed? Do they have a good experience, right? They're dealing with something totally devastating, potentially lifelong chronic illness, pain, whatever it is. You want to make sure that the patient's experience is also tantamount. And then the other thing is, you know, can we do randomized studies in surgical palliative care? It's a little tricky because if somebody needs palliation, I'm never going to tell them, no, you can't have it because you've been randomized to the wrong arm. But, you know, we do need something that is multi-institutional. We do need something that is prospective. So if you have an interest, my email and cell phone number will be on the last slide. So please reach out. These are my takeaways from the last 3 years of all this work. You have to be persistent. You can't give up the first time you've been told no, or the IT guy says the EMR can't give you that data, or you have to dig your heels in and do the work. And because I think this topic is so important, that's what kind of keeps me going and keeps me motivated. Get buy-in, find out who the stakeholders are, bring them to the table, whether that's your surgeons, right? We're still working on our vascular and our surgical oncologists because there's been some resistance in that department, but if you can get those people to the table and have that discussion, then you're more likely to be successful. Don't be afraid to get it wrong. I've gotten it wrong a lot of times, as my mentors have told me, as the reviewers have told me. I've been wrong over and over again, but it's important to get a fresh set of eyes, get outside perspective on it, go back, redo it again, and you will be successful. And then build a team around you. I have a fantastic mentor in Buddy. He's been so supportive of me. Even the trauma surgeons, they have really encouraged me to just really totally pursue this palliative care. My new boss at Arizona has even pseudo given me permission to pursue a palliative care fellowship, even though I just started. And we had a statistician who, even though we don't work for the same company anymore, he still remains completely committed to our project because he really truly believes in his heart that what we're doing is important. So I think it's, that and the collaboration and just reaching out and everybody working on this together is what's going to drive the momentum here. Thank you very much. I'm so grateful to be here, and please email, text, call, anything. I'm happy to work with anybody who has an interest in this.
Great message. Thank you very much. Our final panelist will be Dr. Kimberly Kopecky, who's a surgical oncology fellow from Johns Hopkins. And she has the provocative title of Tomato Nomenclature in Palliative Surgery. But is it really nomenclature? Please, thank you.
Thanks. I'm so glad to be here. I feel like this is the group of people at ACS that are essentially family. It's great to be around like-minded individuals, and I'm so excited that I get to talk after these other wonderful two presenters. So my title's Tomato, and I went back and forth with a few people, like, should I spell it tomato and say it tomato? Should it be tomato with the M-A-Y and then a tomato with the H? But anyways, I hope that you kind of get the talk, and I'm hoping to kind of lure you into this idea that I've been thinking about for the last few months. So we're all here because we're interested in surgical palliative care, but I actually struggle every few weeks with what that even means. I think there's a lot of different facets of surgical palliative care, and the definitions actually kind of get all mixed up. So there's surgical palliative care, which I think I'll go through kind of each of them. Palliative care interventions for surgical patients, which Dr. Lilly published on relatively recently, and then palliative surgery. And I think all of these things are referring to the same thing while meaning different things. And what they mean to different people seems to vary, especially across the published literature. So surgical palliative care in general, I think of as kind of palliative care delivery to surgical patients, kind of regardless of who's providing that service, whether that's the surgeon as a primary palliative care provider or a palliative care trained specialist who's not a surgeon, who's interested in providing specialty palliative care. And I think surgical palliative care kind of offers addressing the physical and psychosocial components of the surgical patient experience, both preoperatively and postoperatively, with a goal of kind of both managing symptoms, but also establishing goals and patient preferences. Often the specialists get called on to deal with the complex symptom management kind of facets, and then guidance through potential active end of life for surgical patients that face those situations. This is a lot of what we published about kind of in a generality, the work of Zara Cooper and Dr. Lilly, amongst many other people in this room, Dr. Berlin, Dr. Mosenthal, Pringle, Buddy, this is like a lot of what we talk about kind of in generalities, bringing the field of palliative medicine to surgical patients. I think then there's also this concept of palliative care interventions for surgical patients. And I think this, to me, falls in two different categories. This is interventions that are, quote, palliative care, which are focused on providing kind of alignment with goals and preferences, pain and perioperative symptom management to surgical patients, and how we integrate those two, which is very similar to the first concept. And then there's also non-surgical interventions that are aimed at ameliorating the symptoms that surgical patients experience that are caused by disease and serious illness. So in the first category, I kind of think of these things as, the use of surgical decision aids, high quality informed consent, advanced directives, pain management, psychosocial support, communication initiatives, end-of-life decision-making, palliative support systems, and then triggers for palliative care consultation. We have decisions aids, and this is, again, like the concept of advanced care planning, which we now have more insight into. And then there's also palliative care interventions in the second category that are really like actual physical interventions that proceduralists are performing, endoscopic interventions to control hemostasis, stenting for palliative indications, IR or endoscopic kind of neurolysis treatments that are like procedural interventions that are focused on handling pain and symptom management, paracentesis, thoracentesis, and then palliative radiation, which is again kind of a palliative non-surgical intervention. And this looks different than advanced care planning and, surgical decision aids. Lastly, and I think this one is the most tricky, is palliative surgery. So there's palliative surgery, I think what we're all considering is the discussion of surgery that's aimed mainly to relieve pain or suffering or symptoms for patients that have serious or advanced illness. And then unfortunately, the literature also includes in this topic of palliative surgery is actually surgery that is non-curative intent surgery. And that this is kind of, as I kind of have investigated and spent more time thinking about this, really what pushed me to kind of try to help break down these categories in my head, because there's quite a bit in the literature of palliative surgery that has no kind of findings that are related to the palliation of symptoms. It's essentially being what I would consider potentially mislabeled as palliative surgical interventions that have nothing to do with patient-centered outcome measures, improvement of pain and symptom management. So I was recently performing a systematic review, and we were going through all of these articles. We had like 10,365 studies that we screened, and some of these stand out as obvious. So the top one says palliative distal gastrectomy offers no survival benefit over gastrojejunectomy for gastric cancer. So, you can read through the abstract if you wanted to, but the title at least tells you that this is palliative surgery, but the authors are writing that the surgical indication is actually non-curative intent surgery is what these people are meaning, because you can tell their primary outcome measure is survival, not symptom palliation. The second one, and I ran into multiple articles like this, it's a little bit misleading, right? Palliative resection for advanced gastric and junctional adenocarcinoma. Which patients benefit from surgery? That sounds like a great question, but if you read their results in the conclusion, the entire discussion here, and I don't know if I have a pointer, but everything in this results section is talking about survival, not actual palliation of symptoms. Here's one more, just because I felt like one wasn't enough, and two is certainly not representative of the entire number of these articles that I had to screen out of my systematic review because they were essentially useless. But again, the title here is intriguing. Role of palliative resection in patients with incurable advanced gastric cancer who are unfit for chemotherapy. I'm thinking like, this is gonna be a great paper. But no, don't be fooled. The results are all about patients who have increased median survival times, and the final conclusion is palliative gastrectomy may improve survival in patients with incurable gastric cancer, with no mention at all of patient symptomatic benefit from these types of interventions. This kind of is like two case studies that kind of led me to some of these thoughts and discussions. So the first one was not the second one is the study that I was just referencing, but before that I did another review that was exploring the literature in surgical palliative care, updated to the domains that were mapped to one of Dr. Lilly's papers. And I ended up rejecting 88 of these studies because they had to do with palliative surgery without being palliative interventions. And that didn't quite feel right to me. And then when I went to go on and do this gastric cancer paper, I discovered that a lot of the quote palliative surgery papers actually also had nothing to do with palliation. So in a group of friends, I think this was just an idea to take an opportunity to think about our definitions as experts kind of in this subspecialty area. when we're talking about surgical palliative care, what are we actually talking about? I think that's the most accepted and kind of broad general consensus. When we're talking about palliative care interventions for surgical patients, what are we actually talking about when we say that? I think that it's kind of funny that what we as a group have labeled palliative care interventions, the rest of the world just calls palliative care. We do, I think, as surgeons, try to find parallels between the palliative offerings and interventionals. Like even Dr. Hoffman yesterday, compared a difficult conversation to the steps of an operation. And I heard that when I was a palliative fellow as well. And so it's just interesting that we find nomenclature that kind of matches with it's like a lot more interesting to talk to a surgeon about like palliative care interventions than just palliative care. And then palliative surgery. And I think this is my biggest plug that I think, especially as we're reviewing manuscripts that are written by people that aren't quite subspecialists in this field, is to really, especially as we take forward in this field, is really teasing apart this palliative surgery term, this last one, which is when are we doing surgery for symptoms? And if we're not even doing surgery for symptoms, when are we monitoring patient-oriented outcomes as a result of surgical intervention versus non-curative intent surgery? I think there was 2 in my review of 10,000 gastric cancer patients that included the language non-curative intent surgery as a reflection of them, meaning when other authors would have used the term palliative surgery. And I think this is a really important clarification. So tomato or tomato? Should we just call this whole thing off? I don't think so. Just kidding. So thank you. I didn't include my contact information, but you all can find me. The room is small. And you can get a hold of me for sure. So thanks so much.
What a marvelous panel. I want to thank our wonderful panelists. In order to be on time for Dr. Joe Beiske, who's the Executive Director of the American Board of Surgery, I'm going to ask that when you get a libation in your hand, you ask them questions. It's been a pleasure being your moderator. Let's give them another hand.
Thanks, you guys. Thank you all so much. Kim, that was a great end to all that.